Okay, thank you. So Les gave me the task to talk about measuring empowerment. And if you think about measuring, we need to think about the concept we are measuring and what questions we want to address. And then we might think about the outcomes. And then we might want to think how we measure it. So it's, can you hear us? Okay, I have a mic on, but I don't know if it's switched on. Is it? Huh? Can you guys? You can hear me? Oh,
It's
okay.
the camera that's trying to hear you.
Oh, okay, get it. So anyway, but having said that, measuring empowerment, I find that a difficult concept, and actually the best way of reason why it's a difficult concept, I took it right out of Wikipedia, because it really covers a lot of meanings and interpretations. And for what is not really clearly for us, it's kind of hard to conceptualize and measure. And so I want to use some alternative concepts that I think it's easier to handle, and still it's a very good communication term because we kind of know what it is when it comes to measuring. There are some alternative concepts that we often use and that can be more meaningful, and where a lot of research has been centered around it, and that's self-management and collaborative care and shared decision-making and person-centered care, because they all speak to the notion of enabling patients to take care of their health. And I show you not everything, but I give you some taste of the types of research that's been done on those concepts, the type of outcomes and how they've been measured. So what is self-management? It's a number of definitions, but it's really often addresses the intervention and training and skills by which people with a chronic condition or disease can effectively take care of themselves and learn how to do so. It speaks to the enabling of people. What the definition doesn't address is, and we think I should include, is the healthy living lifestyle perspective and taking care of your health, even if you are not ill already. And there's a lot of research done and a lot of electronic interventions, electronically delivered interventions, and very much is out there on the internet. And some of the really advantages is that you have a huge outreach. If you first have an intervention, you can really reach out to populations. And here outcomes are mostly measured on the level of the individual, and it allows data collection online, pushing back interventions right back, and has a potential for large data sets. And part of this research is also the role of social networks, context, environment for self-management. And the typical question asked for people working in self-management is, does the intervention make a difference? So the typical research approach might be a randomized clinical trial where you look at health outcomes or behavior or use, how is it used. But very often we also try to understand how does it work, what are the mechanisms behind. Often these interventions are guided by theoretical models, often from behavioral sciences, and often intervention target a behavior or something that is a mechanism to achieve a certain outcome. We might want to affect self-efficacy or knowledge in order to achieve an outcome. So many of these studies are theoretically based. What also is important here is the aspect of tailoring. Who does it work for? When? Under which circumstances? For example, are there subgroups in terms of stages of illness or social economic status? How do they work in different practice settings? So there's a whole number of research questions that are very interesting, and for which we have often the well-established measures. If you talk about collaborative care, which is really if you want to empower the patient in collaboration with the provider, which is an important aspect, then you might look at the productive interactions between an informed, activated patient and the prepared, proactive team. And this is just an example from the chronic care model that has a lot more in there. But when you think about collaborative care, you can't really think about it without thinking of systems, the system around, because that collaborative care is in a context of a healthcare environment. And that leads us to a number of outcomes on several levels, on the patient and provider level, but also on organizational level and system level. And that brings us very quickly into the realm of implementation science. So see how do we actually, if you really want to make an effect on healthcare, and that's what we really want to do, we need to think about how do we use and bring these interventions into the regular clinical practice. And there we have the issue that randomized clinical trials are not always feasible in these fuzzy practice settings. We can't really control all extraneous variables, and we need to use mixed methods, case studies. Many of these people study these things, look at cost effectiveness, and we have to use a complexity science perspective, really, which you talked about earlier this morning, because when you come into these areas, relationships are not linear anymore. It's really complex. So, and then we have the aspect of person-centered care, which is another concept, a meaningful concept, which is more, again, on the interaction level between a clinician and a patient, where we really are concerned about consideration of patients' needs and perspectives, and where focus very often is on shared decision-making, the clinical encounter, what happens there, patient-provider communication, activation, where people both use quantitative and qualitative measures to understand that. But in this area, there has much focus been on processes and not as much as outcomes. And I think always, like, the proof of the pudding is really better health and then patient outcomes. So we have lots to do there. Another concept is shared decision-making, which describes the process on involving patients in treatment or health behavioral decisions, that Les has talked about, that takes into account patient preferences and is based on information. But also, again, in the shared decision-making literature, much of us has been centered around decision aids, decision support tools, decision processes, on treatment decisions, where the issue is we choose between alternatives. That's not always so helpful if you think about chronic illness, which really involves decisions on multiple aspects simultaneously, where the issue is how can we prioritize things that's what matters most to the patient. And I think there's also huge potential for shared decision-making when it comes to behavioral change. How can we help people make healthy choices rather than trading off treatments? And I have a really strong belief and think the worthwhile thinking of eliciting preferences for behaviors itself rather than the outcome, because we know that the outcome in the future doesn't necessarily motivating enough to change behavior. So we might actually think of what is it that makes things fun in my life? How can I integrate it into my daily life? Which are the things that really fit with what I would like? And how can we then help people implement behavioral preferences and fit them into this daily life and stay with it? That's really, really hard questions, but I think there's a lot of potential for decision tools. And also, what are the links between the decision and the implementation of a decision? One thing is we might want to make this decision of tomorrow I will do this or I will stick with that, but do we actually implement it? And what are the relationships then to health outcomes? So these are really important things that needs to be measured. I give you now very quick, brief examples from our own research, just to get a flavor of it. So the example of person-centered care. We have an interactive patient assessment tool that is designed to improve patient-provider communication and patient-centered care. And the idea is to bring really the patient's experiences and the patient's voice and priorities into the center of care and improve communication. So the patient, prior to their visit, goes through a set of questions where they only click on things that apply to them. So problems are are things where I have problems and I want to talk about. And then based on that, if you click on those, it gives you a list of more detailed things. You again click only the things that's important to you, that you want to have addressed. And then you asked of the things you had selected, how bothersome is it to you? And most importantly, you prioritize. What is it that really I want to help with? Because some things you might actually manage quite well yourself. So the system then immediately gives you a summary of what the patient had said, rank ordered by patient's priority. So as a provider, we can immediately see these are the things that most important, they are on top. So we might start addressing those issues. You might think about it not even just like text, we might also think it as a graphical and visual tool, which we have for children who can't read and write, and you might think about same side of approach for people who can't read and write for other reasons without being children, like stroke patients or patients with literacy. So there are many ways of helping people, give people a voice and verbalizing how they can what's troubling them and prepare for their consultations. This is just the output for the children. So what did we measure on these kind of studies? There's actually quite a number of things you can be interested in. So first thing we did a randomized clinical trial, repeated measures, where we looked at whether it made an effect on care or whether it made an effect on patient outcomes. So we looked at whether or not there were more symptoms addressed in the patient charts, and we looked at symptom distress and priorities for care over time or need for help over time, and found significant reduction in symptom distress over time in cancer patients and significantly need for help. So we might think of, if that's a good approach, why don't we do more of these studies and test it in other populations, because the approach is generic. But then we also wanted to understand, okay, so what's then the perceptions of the users? How do patients like it? How do providers like it? So these things you do with more qualitative measures, focus groups, interviews, kind of things. So and we looked at experiences and satisfaction. Care providers said it's really improved communication. It made them more right on target, helped them understand what the problem are, get to know the patient faster. Patients are better prepared, and it really helps them verbalize what the problems are. Gives them a voice and gives them more sense of coherence and control. But then another way of using these data, if you use it, it's not only does the intervention has an effect, we might also use this data to understand the population, because now as it's implemented in our clinic, where we have thousands of observations, we can see, okay, what from the patient perspective are the most often reported symptoms and problems over time during your illness trajectory. So, and what we found here is actually, except that the sequence change, there's like 5, 6 things that go along through the whole illness trajectory. And if we have this type of knowledge, then we can really tailor intervention and make interventions to help people deal with these things and help improve patient care around these things. So
Is each line a person? Is each line a person?
No, this is the rank. This 384 persons,
right?
And this is the rank of what is the most often endorsed problem and rank of the most distressful symptoms.
Oh, I see.
Right. So at baseline, the most stressful symptoms for those is worries.
I see. And then at 0 to 3 weeks, it was sleep. And
right.
Yeah.
So it's
And what are the colors mean?
No, it's just to make change. Just to see it.
It's a visual.
But
cue.
eating is always purple, except all those are white. They're all different.
They stopped eating them.
Well,
Did we just
the
run out
top
of colors?
5.
Oh, yeah.
No. So
Color has no meaning.
color has no
I see
meaning.
brown
It's
colors.
just, but it's just to see a pattern, because here we see, you know, when people are diagnosed with cancer, they're terribly worried. Then it goes more into like relating to, you know, going through chemo and all that. But then the worries come back up, and so it's like just seeing the pattern. But so anyway, but it helps us actually understanding. We can use these type of interventions also to learn about the population and how we can improve care by understanding what is the most important things for from the patient perspective. So that's more like the point. But then we also wanted to know, so what happened in the actual consultation? Because we really want to also improve the interaction. So we did another study where we studied actually the communication itself, where we audio taped consultation with and without the intervention. And and we did it with nurses and we did it with physicians. And so we looked at like number and types of symptoms addressed, but we were really interested in communication behavior. How did it affect that for patients? And how did it affect for providers? And we see it had a significant effect on question asked, follow-up questions, information giving, and so on. All that is published. So, so like an example, given we have an interactive patient assessment tool, we can study communication variables, we can study cognitive variables, how does it affect the patient to go through this, but also processes of care and clinical outcomes. So the other example, when we go to self-management, which is maybe kind of the closest to empowerment, I don't really know, but people are usually 99% of the time at home and not with us as peer providers. So that's where there's a need of interventions to help them. And so the web choice is a multi-component intervention that has the assessment monitoring thing, like the choice tool, but it also has tailored advice based on what you say your problems are. You get up a list of things that you can do with that particular problem. There's a forum for group discussion with other patients. There's a messaging system where you can ask your provider questions. There's a diary. And there is links to other evidence-based websites. And what we did here, well, we started out with a real regular repeated measures randomized clinical trial where we wanted to look at health outcomes. Very standard. We looked at symptoms, self-efficacy, depression, social support, found significant reductions in symptoms and depression. But it also gave us an opportunity to understand patients' questions and concerns based on the email messages they had sent to the nurse through the system. And it was like extremely eye-opening of what questions and concerns people struggle with at home, which is a very, very rich knowledge base for us and a next step to tailor interventions and how can we address them. And it also helped us to understand how can we leverage these types of interventions and what role can the nurse play, for example, in answering these messages and supporting patients at home while they're sitting in the evening and have their questions and wondering about side effects and all kinds of things and what they can do and if they can, if it's dangerous to drink a glass of red wine or what it is. So it also helps us understand how we might actually redesign our healthcare system with different models. When it comes to patient-centered collaborative care, which is another important concept, then we really get into the area of implementation science, because then we really talk about collaboration between the patient at home through their web choice interface that now has Connect, same intervention, but where then care providers have a team-based approach and can collaborate with them, but together with the patient, where the patient is the center of communication and information exchange. And that adds a completely different layer of complexity. And this is from our studies. You don't have to read it, but kind of research question you would ask for that type of thing, like we do, what are the predisposing and enabling and reinforcing factors related to adoption of a system in practice? What are the barriers? How does it influence interaction, communication, organizational processes? How do people use it? What is the typical workflow? What are the perceptions? And most importantly, what is the unexpected positive or negative consequences? Because here we can really learn a lot. There are several frameworks, but one framework that can guide us for these kind of questions is the REM framework by Glasgow. It's a framework to evaluate implementation success. Again, what does it take and who does it work for and how? And Sue and I wrote an article and extended that framework into the informatics realm. And here you would typically use mixed methods, Otherwise, it's really hard to address those kind of questions. So what the REAM framework addresses, and what's really important to measure for electronic interventions practice is these 5 dimensions. Do people actually use it? What is the participation rate? Does it have an impact on key outcomes when you implement it into regular clinical practice? What is the willingness to offer the programs, the adoption aspects? How well is it implemented? And is the system maintained when this first is implemented into routine practices? So these kind of things help us understand whether we are actually successful or not if we implement electronic systems into practice. However, there are a number of things we know really little about, and before we know a little about it, it's also hard to measure it. And so we still have a long ways to go to learn how to successfully implement patient-centered systems into collaborative care practice. And so we really need more research in that area, and we also need more theoretical frameworks to guide us, because so far they haven't really been empirically tested too well in this kind of context. And so that's an important issue. And then what we really learned is there's really no one size fits all, and that's an obvious thing. But usually when we design interventions on the internet, we usually compose them of multiple components. But we really don't know what the effective ingredients is. There might actually components that doesn't do a thing at all. And so we do our 3 years randomized clinical trials, and if we are lucky, we find a positive outcome. And if not, well, there might be still components that be good, but they're diluted by something else. So I think we really need to think about what are the most effective interventions ingredients. And there are actually some new methods coming out from, actually inspired by engineering, about how to quickly do through a series of small experiments, get to what are the effective ingredients, and then you bundle them together in a multi-component intervention, and then you do your randomized clinical trial. But it's a very more effective way of getting at speeding up the knowledge about what works. And the other thing is, how do we adapt interventions to user characteristics and settings and context of use, like the issue of tailoring and screening. So what works best for whom? There's moments of opportunities where people are more acceptable for information and learning. The people who are unresponsive to something or things are not really right. There are preferences that's different. Some people love something and somebody hates it. So we are not really we have a long way to go to do this and measure what are the tailoring variables, how do we do things. I think we also need to conceptualize healthcare environments more as complex systems where relationships are not linear. So lots of the measures we use assume a linear relationship between things, which is not always true. So we need to use mixed methods and other approaches. We are pretty good at interdisciplinary research because this is really a necessity, and there is a need for adaptive intervention. So it's an exciting area, and along with the new questions, we might also have the need to develop new measures, or we can use the measures we have. Thank you. That was rushed because Les said I had.